Okay, so I see we're live on Facebook. Okay, good evening, everyone. Thank you so much for joining us. We're going to give a couple of minutes so others can join us. Okay, it seems like everything is working and we are live now. Okay, again, hello, everyone. Thank you again for joining us. And yes, please say hello and let us know where you're connecting from. Well, people from all over the country, and we have some others that are going to be participating for other countries outside the US. Welcome, everybody, to today's webinar, What to Expect During an Epilepsy Monitoring Unit, or our commonly known EMU stay. This webinar is brought to you by ItsYourEpilepsy.com. My name is Fernando Cubillos, medical advisor for ItsYourEpilepsy.com, and I will be hosting this webinar. Our speaker today is Dr. Ammar Kheder. He's a neurologist, epileptologist, director of the Comprehensive Pediatric Epilepsy Center, and associate professor of neurology and pediatrics at Emory University in Atlanta, Georgia. During this webinar, you will be able to learn on how to prepare and what you may go through during and after an epilepsy monitoring unit stay. And but before we start, we have some housekeeping items. Your audio and video will be muted for the entirety of the webinar. This webinar will be recorded for future viewing. You will have the opportunity to ask questions by typing them in the chat box. Please submit all the questions that you have at any time. And we will provide these questions to our presenter today, and he will be happy to answer them after his presentation. We are taking the opportunity to thank our collaborators today, the Epilepsy Foundation, the Epilepsy Foundation Eastern Pennsylvania, Epilepsy Foundation Los Angeles, Colorado, and Wyoming, Epilepsy Foundation Minnesota, the Chelsie Hutchinson Foundation, the Pediatric Epilepsy Surgery Alliance, and the International Mexican League, CAMELICE. Dr. Ammar, thank you again for your important contribution, and please take it away.
Thank you so much, Fernando, for the kind introduction, and thank you for the invitation to speak today. And thank you to the audience for joining us for this talk on EMU stay. The outline of my talk today is going to start with some definitions of epilepsy. Then I'm going to talk to you about the purpose of the Epilepsy Monitoring Unit stay and how to prepare for it and what to expect during your stay, and then ultimately the discharge process once the EMU stay is completed. And then we'll conclude with some discussion on support and resources. I have no conflict of interest. Epilepsy is a neurological condition that is characterized by unprovoked and recurrent seizures. And this is very important because we do see seizures that can sometimes be triggered by an illness. And those are provoked seizures that are somewhat different from the definition of epilepsy. For epilepsy as a condition to be diagnosed, the person has to have two unprovoked and adequately separated seizures. When we talk about seizures are usually a symptom of an underlying neurological condition that could encompass epilepsy, amongst other things. And commonly, what causes epilepsy is either a genetic predisposition, or in other ways, it could be a brain injury or insult of some sort, be it a stroke, be it head trauma, and obviously things like brain tumors can also cause seizures or epilepsy. There are numerous triggers for seizures, and some of those are unique to individuals, but most commonly the triggers for seizures are usually missing medications and sleep deprivations. There are some other common triggers, And there are triggers that would classify the epilepsy as reflex epilepsy. For example, there are types of seizures that are triggered by hot water or cold water or by reading, and these fall under the umbrella of what we call reflex epilepsy. If we look at the incidence of epilepsy across age spectrum, so on the x-axis, we see age groups over the years, and then on the y-axis, we see the incidence of seizures over the years. We see that epilepsy tends to occur in the young and in older adults. And when we talk about causes, as I mentioned earlier, we can think of those as being kind of somewhat under two categories. One is genetics, and the other one is acquired, and that can fall into a multitude of issues such as trauma, tumors, infections, etc. And this is just looking at the data a different way across age spectrum. So in the very young, from ages to say 1 month to 14 years, it's usually malformations in the brain or head injuries. Whereas in older adults, it's usually stroke that tends to be the bigger cause for seizures. When we talk about the type of seizures, generally speaking, we talk about two big types. One is called focal seizures, and the other type is generalized seizures. So in this cartoon here, I'm showing a picture of a brain and a tracing of an EEG. And in a healthy brain, usually there is no scarring, there is no dysfunction in the brain, and the tracing looks normal. In a person who has focal seizure, usually the seizures emanate from one area or one spot within the brain that could potentially then spread to the other parts of the brain. And that's what we call focal seizures with secondary generalization. Focal seizures tend commonly to be caused by some scar tissue of some sort, so brain injury, that be a stroke or a tumor, or some sort of developmental anomaly within the brain tissue. The other type of seizures is the generalized seizures, where the abnormality, the abnormal activity in the brain starts all over the brain at once. And what you see on this tracing here with focal seizures, that the abnormal activity is only in one area, where here it's all over the EEG. And generalized seizures typically indicate a more widespread process that is underlying epilepsy, most commonly genetic. Sometimes it can be developmental as well. So moving on to discuss the purpose of the epilepsy monitoring stay. The EMU stays are usually critical in order for an accurate diagnosis and treatment planning. One of the biggest reasons to come to the epilepsy monitoring unit is to really figure out whether the person has epilepsy in the first place, or is it something else. There are many types of movements and events that could mimic seizures. For example, in a young child who zones out in the classroom, that would not necessarily be due to a seizure. Having an EMU stay would allow that child to stay in the hospital for overnight, and would allow the physician to capture those events and look at a 24-hour worth of brain activity data that would guide the treatment a little better. So during the stay, what typically happens is we match the brain activity that is captured from the EEG with any symptoms that the person will experience during the test. So for example, if part of the epilepsy symptoms, the person is experiencing flashes of light, or sense of deja vu, or some abnormal sensation, we can look at that specific episode and look at the changes in the brain activity to match it, to see whether it would constitute seizure activity or is it something else. And broadly speaking, the indications and the objectives of EMU stay falls under two categories. The first one is seizure characterization, and as a result of that, medication management and adjustment. And by that, I mean, as I mentioned earlier, figuring out whether what we're dealing with is seizures, and if it's seizures, what type of seizures. Because treating focal seizures is slightly different from treating generalized seizures in terms of medication choice and also in terms of further steps down the line should the first medication or second medication fail. The second objective of EMU stay, or the second indication, typically is centered around pre-surgical evaluation. And epilepsy surgery can be considered for patients who have adequately tried 2 or more medications. So if someone has tried 2 or more medications adequately, and by adequately, I mean they got on a decent dose of the medicine, they did not have any side effect, and they were still having seizures, then pre-surgical evaluation can be considered. And with pre-surgical evaluation, the goal is to find out if the seizures are coming from a specific area within the brain that could potentially be amenable to some sort of intervention. The intervention can be something minimally invasive, such as laser procedure. It could be a resection by removing, through craniotomy, a little bit of the brain tissue that is scarred or involved in seizure generation, or it could be some type of device, such as the neuromodulation devices, the responsive neurostimulator, or the deep brain stimulation. So how do you prepare for the EMU stay? Usually when your physician orders the test, it goes to the EMU team, who will then call you to make arrangements for a convenient date for you to come to the hospital. Prior to going to the hospital, it's always good to discuss ahead of time with your healthcare provider whether there is any change to your treatment before you go to the hospital. Typically, these conversations take place with your doctor when he orders the test, or sometimes your doctor will notify the staff who are working with you to arrange your stay to make some medication adjustments. As part of the EMU admission process, we sometimes taper medications, and some medications stay in your system a little longer than just a day or two, meaning if we cut down the medicine, we might not see the effect of it until much later on. So to make your EMU stay more, informative, sometimes what we do is we cut medications even before you go to the hospital. But that's something that you would probably want to discuss with your healthcare provider before you go. And I would say we always encourage patients and families to have open communication with us about any questions or concerns they have before the hospital stay. We fully understand that this is might be a new experience for a lot of our patients and families, and we understand that they might have concerns or fears about what will happen and what it will mean. So discussing any concerns you may have is always welcome. As you prepare to go to the hospital, one of the big questions that we get asked is what to pack. And what I would say is there are obviously a lot of items that are available at the hospital, but it's always optional for you to take things that you may need. So for example, it is essential to pack things such as your personal identification, your insurance information, because you're going to need that when you check in the admission office. But anything that you need for your comforts, then you can certainly bring those along. And I'll go over some of those. What I would recommend strongly is you wear clothes that are comfortable and can open easily from the front, such as a button-down shirt or a pajama top, because when the EEG electrodes are placed and when the wires are placed on the head and on the chest, having something that would easily button up and down would be much easier to remove than having something like a fleece or a top. So it's more for your comfort, really, because it will make putting the clothes on and off a lot easier. If you prefer not to wear your own clothes, the hospital has hospital gowns, and they would be able to provide you with that as well. I would strongly recommend that you bring your own medications, including the doses and the schedule of those medications. So you can bring your medication bottles, and make sure you mention that to the nurses and the staff taking care of you in the hospital. There are some situations when some medications are not available at the hospital, particularly medications of the extended release formulation or some of the newer medications. For some patients who are taking medications as part of a clinical trial, it will be very unlikely that this medication is available at the hospital. So what I would say to my patients is always pack your own medications with you, bring them with you, let your nurse know that you brought your medication, and that way your doctor and your nurse can actually verify the medication, make sure that is entered to the hospital system accurately. Oftentimes your medications are available at the hospital, and they will be administered by the nursing staff throughout your stay. But it is always better to bring your own medications just in case. You can obviously bring your things to keep you busy and keep you entertained. So things like books, music, any personal items that might make you more comfortable. The hospital will provide you with personal hygiene items, but you may choose to bring your own if you wish to do so. The hospital also will provide you with meals and snack, but if there are specific snacks that you like, you might wish to bring those with you as well. By the same token, you can bring your own pillow. The hospital will have pillows, but if you prefer, you have a specific pillow that provide you more comfort while you're sleeping in the hospital, then you can definitely bring that with you. Stuffed animals, special blankets, all of that is perfectly fine. For people with disabilities or people who use special devices such as CPAP, for example, or have other needs, I think make sure you discuss this with the team when you get called about the admission. I think for something like CPAP, we encourage people to bring that with them to the hospital. I would strongly encourage you not to bring valuables such as cash and jewelry. I mean, cash in small amounts is obviously not a problem if you want to buy things in the hospital, but I would strongly recommend against bringing valuable things to the hospital, just in case. Moving on to the admission process. When you are admitted to the hospital, you will arrive. You'll check in at the security desk or the front desk, and then you will be guided to the admission office, where they will check your identification, your insurance, your paperwork, and then you will be escorted to the Epilepsy Monitoring Unit, where you will meet your team. And your team will include the nurses, the EEG technologists, the doctors, the nurse practitioners, the physician assistants, social work. If it's a child, you will see child life, who would help keep the child busy and entertained during the EEG hookup process. There is also a lot of support staff, including catering and housekeeping, etc. So you will meet a lot of people in the hospital. And in a teaching hospital environment, you will likely to meet with trainee doctors, residents, fellows, as well as medical students. You may also see nursing students and EEG students as well. Depending on the hospital you go to, a lot of the hospitals have individualized rooms for monitoring, where you're allowed to come in and bring a family member potentially with you. It's a standard hospital room that would have a bed and a couch, have your own bathroom, and would have the standard equipment with it. What is unique about the epilepsy monitoring unit room is it will have the equipment for EEG monitoring, including cameras. During your stay, you will have monitoring via the EEG that is hooked up to your head, as well as a camera. And usually the cameras are directed towards the bed area and what is surrounding it. And we highly recommend that you stay within that vicinity so that if something happens or if you have a seizure, your physician can see that on the video, as well as review that in conjunction with the EEG. Once you've gotten to your hospital bed, one of the early things that will take place is that the EEG technology will set up the equipment. And this is a process that can take an hour or two to complete. There are usually 23 electrodes that look like small discs and attached to wires. These wires are then connected to a small box that is then connected to the computer. In some instances, there's very few hospitals that actually have wireless monitoring devices where the box is connected to you, but you can move it freely. There is no cable attached. But this tends to be the rare situation. Most hospitals actually have the wires connected to a box and then to a cable. And what will happen is, as I've shown in this picture, the technologist will measure the head, because for the signal to be as accurate as possible, we usually use a system called the 10-20 system, where it's a percentage of your head circumference and some of the measurements that the technologist will do in order to measure the brain activity accurately. So what they will do is they will use that system where they measure the head, and then they will make marks on the skin where every electrode needs to be. Then they will secure the screws over those marks with some glue, and then they place a head wrap around the head. They will also add additional stickers to monitor the heart. Usually, there is a close relationship between the heart and the brain, so we like to monitor those together. And in fact, if you look at the standard EEG tracing, at the bottom of the EEG tracing, we usually place a heart EKG channel as well. As I said earlier, we strongly recommend that you stay around the bed area where you can be in view of the camera. Some institutions have more than just one camera in place, and they can actually, the technologists, as they're watching you during your stay, they can track your movement and move the camera around. So don't be alarmed if you see the camera move in the room. It's probably them moving to make sure they capture your movements if anything happens, so that they have it on video. Some hospitals actually have marking on the floor, and they can ask you to stay within certain demarcated area. Usually has a different color from the rest of the room. You can obviously disconnect the cable if you need to go to the bathroom, and that's perfectly fine. What I would recommend is make sure that you seek help from the nurses or a family member, because sometimes, you could trip on the cord, or you could feel dizzy in the bathroom. It's better to have someone with you at all times when you're disconnected, in case if you need any help. Once the EEG is connected, sometimes before the EEG is connected, you will have a physician trainee, a resident or a fellow or a physician assistant or a nurse practitioner ask you a question about your symptoms. They will confirm your medication, and they will perform an examination and document all of that in the chart. As I said earlier, one of the key aspects of your interaction with the clinical team is making sure that we have accurate information about your medications, your allergies, etc. The daily routine in the epilepsy monitoring unit will be primarily around monitoring your brain activity 24/7. So all day, there will be someone watching the monitor, looking for any signs of seizure activity on the EEG, or if you alert the staff or your family alert the staff that a seizure is taking place. There will be daily rounds with the team, including nurses, doctors, trainees, and students. The nurses will do medicine rounds as well, so you'll have, depending on what time you take your medications. The nurses will also check on you and take your vitals periodically during your stay. As I mentioned earlier, oftentimes you're allowed to have someone stay with you during your stay, but you're also allowed to have visitors. So if you would rather have your family, loved ones, or friends come visit you, that can be arranged as per the hospital protocol and policy. And depending on the time of the year, I think when it's winter time, sometimes there are more restrictions. And certainly during COVID, we've seen more restriction on visitation than usual times. When you're not having visitors, or you're not talking to your team during rounds, you can do any activities you like. If you brought your books or your computer or whatever entertainment, you want to watch movies, etc., or you can just nap. As part of facilitating data collection during the EMU stay, we often try to trigger seizures during the EMU stay. One of the very first things we can do is we could cut down the medications, and sometimes we do that even before we come to the hospital, or we could do other procedures to trigger seizures, such as flashing lights in the eyes, hyperventilation, or sleep deprivation. In some hospitals, they also try to induce seizures by giving some medications that are known to provoke seizures or lower the seizure threshold to some extent. So certain medication have warning that they could potentially have someone have a seizure if they're liable for seizures. So in some institution that can be administered as well. So one of the big questions that we get asked sometimes is, is this process safe? And I would say it is safe because we're not intervening on the brain. The only thing we're doing is we're recording brain activity that is produced naturally. So we're passively collecting that data. The problem we run into is that because we use the glue on the skin and the scalp, sometimes people do get a little bit of irritation, and that can be, sorted out with some over-the-counter creams. The other extreme of this is that if there is significant irritation, that might need some, antibiotics or some other interventions, but we rarely resort into that. As I mentioned earlier, we do produce seizures, so it's kind of quite frightening to know that you're trying to control your seizures, but here you are in an environment where you're almost being asked to have a seizure. But what I would say is, if there is a place for anybody to have a seizure, it's the Epilepsy Monitoring Unit, because your brain activity is being monitored all the time. You have a fully staffed unit. You have nurses, nursing assistants, doctors, technologists. You have a big group of people who can take care of you. And usually there is lots of safety protocols in place to ensure that your safety and well-being are very well taken care of, including plans for using rescue medications. For example, if you have a seizure, usually there is pads on the floor. Let's say in case if someone falls after a seizure, the sides of the bed are padded too, so that in case if someone is having a seizure and they knock their head on the side of the bed, these are padded. So I would say it's very safe. The only issue is the minor irritation of the skin, and obviously the thought that you're going to be in the hospital to actually have a seizure. So you're sitting in anticipation of having a seizure, and that by itself can be distressing. And with that comes some degree of stress and anxiety, knowing that you're in a place where you're expected to have a seizure and you're being watched all the time for seizure activity. And we fully understand that this can be very challenging. Sometimes doing things like meditation, breathing technique can actually help. If you have any anxiety or stress, I would say, as I stressed earlier, open communication with your team about what you're concerned about. We've had patients who would say to us that I'm afraid of having a seizure, and we fully understand that. But talking openly about your thoughts and about your concerns and about your anxiety will go a long way. And I think everybody in the hospital is there to help you and really take good care of you. Some support from other individuals. I think for kids in particular, Child Life can be quite helpful. They can help kids actually cope. We tend to try to really talk through any problems with our patients to alleviate any anxiety they may have. You can also talk to the chaplains, because that can be a big source of comfort for many of us. I would stress on communication, and this goes both ways. We as healthcare providers, we should do our very best to communicate with you, but I would also say to patients, communicate with your team. Any concerns, any changes, anything that comes up. We've had patients who had some family emergencies and they were halfway through medication taper, and they asked us to really help them through this process. We're there to really help you as much as we can. So open communication, transparency, we will make sure that we support you in every way we can. So what will happen if you have a seizure, whether it's a convulsion or a focal seizure where you just lose awareness, but you don't actually have the shaking and the twitching in your arms or legs? There is always a response protocol in the hospital where staff know exactly what to do in the event of seizure. So they make sure the bed rails are up, that you're in a safety position, so a recovery position on the side. They'll have oxygen ready, they'll have medication ready, and they monitor your vitals to make sure that you're back to baseline. And in case where the seizure is going on for over a certain amount of time, they can intervene and give you medications. And then based on that data, a decision can be made as to whether we need to make any further medication adjustment. So for example, if someone had 2 seizures within an hour, do we need to make adjustment to the medication because we don't want them to have too many seizures? Sometimes having too many seizures within a short amount of time would not be as helpful. We like to make sure that we have a space between seizures. We have some adequate time so that in terms of what we're looking for, the data would look much better than having back-to-back seizures. And it's not very comforting for patients, obviously, to have seizures one after the other. The medication adjustment can be necessary based on what I mentioned earlier. And ultimately, at the end of the EMU stay, if we identify what type of seizures you have and what treatment we need to give, the decision about the medication usually, in my view, is a collaborative effort. It's between you and your doctor, and they can tell you about potential side effects, potential benefits, and ultimately you make that decision together. And even as hard as we try to make the best choice, sometimes people have side effects, unexpectedly also, because we're all unique in how we metabolize and react to the medications. So again, it's a matter of communicating with your doctor and making sure that you're monitoring for any issues. and giving feedback. What do we usually find at the end of the stay in the EMU? It's number one is we capture epileptic seizures, and we figure out where they're coming from. And we then categorize the epilepsy as being either focal or generalized. And we look at the medication and we see what we need to do. And based on your report of your baseline seizure frequency, we can make recommendations. If you have been referred by a physician from an outside, your community neurologist or a different organization, we usually communicate those with your primary neurologist, and we try to find a path forward in terms of what adjustment we need to make. So that would be the best case scenario. There are situations where we see evidence of abnormal activity, but we don't capture seizures. And I would say this would still be very helpful, because if we see abnormal activity and we can identify this as being focal or generalized, can also guide the treatment, even if we don't see evidence of seizures. Occasionally, we see completely normal brain activity and we don't capture seizures. And that can be a major source of frustration for patients and for providers as well. So you come into the hospital, we wean the medication, you stay up late, we do everything we can, you do everything you can to get a seizure, and nothing happens. And I would say, as frustrating as it can be, it's unfortunately, it happens. And part of the reason that this may happen is because you're not in your normal environment. You're not exposed to the usual stimulation that you have at home or at work or in your daily routines. But if that happens, there's always remedy. We can always repeat the study, or we can work on alternatives, capturing videos at home, doing a study at home, etc. Also, occasionally, we do find that people that would come to the hospital with the question of having epileptic seizures, but we find out that they actually don't have epilepsy. They have what we call non-epileptic spells. And if that's the case, your team will discuss that with you, and they will guide you to resources and to the necessary help. Once the test is complete, the electrodes obviously will be removed. The technologist will use a solution to remove the glue from the hair and from the scalp. And you would be able to wash your hair. And obviously, if there's any signs of irritation, you can speak to your team. Usually, something like Neosporin or something like that would be sufficient to take care of that. But if there's something more than that, then they will be able to guide you as to what to do in these situations. We typically review the findings with patients before we discharge them home, because we review the studies on a daily basis. And let's say if you stay for 24 hours, we will have we will review the study before we send you home, because the discharge is typically based on the findings. Every institution have a different workaround how they do this. Sometimes they discharge you home and they have you see your doctor within the next few days or within a week, and they'll have them discuss this with you. But at least in my practice, what I do is I discuss the findings with the patients, and then I communicate those with the primary person, the primary neurologist. And once you've left the hospital, you can transition to your regular routine. It's very rare that sometimes after discharge from the hospital, if your medications were weaned during your stay and you get discharged, that sometimes we do see this rarely, that people do have seizures after discharge from the hospital immediately or within a day or two. And if that's the case, it's probably because the medications have not really been built back to their usual levels in your blood. And if you have concerns about that, I would strongly recommend that you just discuss that with your doctors, with your team, before you go home. There are a lot of valuable resources online and in the community. I think connecting with support groups, with the Epilepsy Foundation of America, but also with your local epilepsy foundation in the state where you're living, can be a major resource and help. There are educational materials that are printed out in institutions. Most institutions will provide you with a printed material or an online material for your EMU stay. So you can use all these various resources. And with that, I'm going to end here, and thank you all for your attention.
Dr. Kheder, thank you so much for such an informative presentation. Questions have been coming in, and I'm gonna start with one of the questions from one of our participants. Does the removal of medications during an EMU stay make a patient more susceptible to those medications not working afterwards?
It shouldn't. So when we cut the medications during the stay, most of the time, you put the medication back on and they should work as before. Removing the medicine should not really reduce their efficacy if they were to be introduced a few days later.
Excellent. Our next question is, if the results from a current visit are not conclusive, do I have to go back to the EMU, and for how long?
Great question. So this is a situation that can be challenging for patients and for doctors. Let's say there is a question of type of epilepsy versus there is pre-surgical evaluation. If it's a question of just type of seizures, is this focal or is it generalized, sometimes there are substitutions. It ultimately depends on your comfort and your discussion with your doctor. So what could happen is you could take a video of the seizures. You can have your family or your friends take a video of the seizures. If you're comfortable doing that, submit that to your doctor as an alternative. Because if they recorded, let's say, 3-4 days of normal activity, and you don't wish to come back to the Epilepsy Monitoring Unit, we need to look at alternatives. So one of those alternatives would be to just look at the video. And sometimes by just watching the video, your doctor might be able to actually tell what's going on. Another alternative is to do at-home test, or what we call the ambulatory EEG test, where you will have the EEG electrodes placed on your head, wrapped. You will be given a box, then you take it home for anything between 1 to 3 nights. Then you bring it back, and during that time, we might be able to better see activity because you're having the test in your home environment as opposed to being in the hospital. So that would be another option. In an ideal world, what we would prefer to do, if you're open to it, is to repeat the admission a few weeks later. And what we might do is, in that scenario, is cut the medication potentially before you come to the hospital to increase the possibility of getting seizures during your stay. So that's something would be that we could potentially do as well, is that we bring you back if this is something you're willing to consider, but we cut the medicine, not necessarily fully, but to some extent before you come to the hospital to increase the yield from the EMU.
Yeah. Dr. Kheder, you have mentioned something that is very important. It's about the environment. We hear very frequent from people with epilepsy that there are some items around their bedrooms or the houses that triggers their seizures. And when they go to the EMU, they don't present any brain activity that may think that they have epilepsy. So I think that's something that patients and families should share with the teams. It's about try to identify all those things that may trigger seizures at home.
Right, absolutely. Yeah.
Well, our next question is about what happens if I'm taking other medications different than my epilepsy medications? Should I bring them to the EMU?
Yeah, I would say bring all the medications because all your regular medications will be written up for you to take in the hospital. So if you're taking blood pressure medication or even baby aspirin or cholesterol medications or any other type of medication, we don't like to disrupt the routine of those medications. The only medications we would adjust during your stay will be your epilepsy medication. But as I mentioned earlier, it's always a good idea to bring all your regular medications with you, be it the epilepsy medication or the others, so that the team can look at those and they can write them in your chart so that the nurses can give them to you on a daily basis in the same routine that you take them at home.
Excellent. Another participant is asking about what type of diet or dietary restrictions the individuals at the EMU must have.
Generally speaking, there are no dietary restriction unless you have a specific dietary requirement. So let's say someone is gluten sensitive or someone is already on ketogenic diet. Then in that situation, when your team is placing the orders for your stay, they will put a specific requirement so that for the catering staff to know what to serve you during your stay. But in general, we don't put patients on any dietary restrictions during their stay.
Good. Thank you, Dr. Kheder. The next one is more about clarification. The participant is asking about the hospitalization at the EMU is just to adjust or change medications?
That would be one of the goals of coming to the EMU is, let's say someone is having many seizures at home and they've tried different medications, they've tried adjusting the dose of the medication, they continue to have seizures. Coming to the EMU and making adjustment and watching for the results of those adjustments can be beneficial. But the two other reasons to come to the epilepsy monitoring unit would be to actually, figure out what type of seizures or epilepsy you have, because that can guide the treatment better. And the other reason is to see if there is a potential for epilepsy surgery, should this be something you wish to proceed with. Provided there was adequate trials of seizure medications before we move in that direction.
Excellent. Thank you, Dr. Kheder again. And this one actually is coming from myself, and it's about IV lines. We hear from people that go through the process of the EMU stay and keep asking about why should I have one or multiple IV lines? So could you share or elaborate on the importance of having all these IV lines?
Yeah, great question. So the IV lines are usually placed in order to make sure that the team has access to deliver rescue medications in case of big seizures. So one rationale for placing those would be to make sure that if there is a seizure and the team need to administer medication, usually the intravenous route is more efficacious, especially if someone is unconscious after a seizure and they're unable to take medications orally, then giving the medication intravenously. Invariably, the IV lines can be used for other purposes as well. So when the IV line is placed, we can collect blood samples and also check for medication levels. So if you're on certain medications, we check the drug levels to make sure that they're in adequate range. And the other reason to have an IV line is sometimes if there are any issues related to replacement, such as IV fluids or other supplements that are needed during the stay, the IV line will provide easier access to give that kind of treatment as well.
Well, that's all we have, Dr. Kheder. Thank you again for today's webinar, and your information and all the answers are very, very helpful. And I want to thank all the participants, and we will invite you again for future webinars. Also, we want to remind you that this webinar will be available at ItsYourEpilepsy.com. This recording will be available pretty soon, and you will be receiving an email. And if you want to learn more about what to expect at the EMU, you can also check additional information at ItsYourEpilepsy.com. Thank you, everybody, and have a wonderful night. Good night, everybody.
Thank you very much.